Hello, everybody. This is Counselor and Professor Rob Alexander, and I am here today to talk about Chapter 14, which has to do with sexual function difficulties, dissatisfaction, enhancement, and therapy. As always, just a constant reminder, I want you to take copious notes. That means take a large amount of notes, okay? As I go along, as I am talking, you are writing. Taking notes helps you to retain information. So we're going to go ahead and get into chapter 14, right? So in chapter 14, we talk about sexual function, sexual difficulties, definitions, types, and prevalence, the physical causes of sexual function, difficulties, and dissatisfaction, psychology causes of sexual function, difficulties, and dissatisfaction, and sexual function enhancement, treating sexual function difficulties. You are taking notes as I am speaking. Okay, so sexual function dissatisfaction, or alternative term to sexual dysfunction. Common outcome of a difficulty in sexual functioning. Classifications of difficulties and dissatisfaction based on the medical and feminist models. DSM 4, Working Group for a New View of Women's Sexual Problems. The DSM 4 definition of sexual dysfunction: disturbance in sexual desire and in the psychophysiological changes that characterize the sexual response cycle and cause marked distress and interpersonal difficulties. So this is the DSM-4's version or definition of sexual dysfunction. What it is basically saying is changes that happen in the mind and the physical response of the sexual response cycle can leave a form of distress or sadness, and also difficulty communicating person to person, or couple to couple, or individual to individual, right? So a working group for a new view of women's sexual problems. The women-centered definition, since that jargon was a little hard to understand, hard to gather, as discontent or dissatisfaction with any emotional and physical or relational aspect of sexual experience, right? When it goes beyond communication, the discontent means the unhappiness. So when we look at the DSM-5 as sexual dysfunction disorder, they go from female sexual interest arousal disorder, male hypoactive sexual desire disorder, erectile disorders, so on and so forth. So I want you to take a break, take note, take in everything. The percentages of sexually active men and women in Britain, aged 16 to 74, reporting selected sexual problems lasting 3 months or more. Okay, so it has it broken down from male problems and female problems, the lack of interest versus the lack of enjoyment, how many felt anxious, how many felt physical pain as a result of sex, how many felt no excitement or arousal during sex. So look at all the percentages. Take a pause, take a break, take note. And this diagram breaks it down even further. We look at difficulty in reaching the climax, reach climax more quickly than you would like, trouble getting or keeping an erection, experience one or more of these problems, experience two or more of these problems. All right. So this diagram has to do with arousal, pleasure, erection difficulties, pain, and orgasm. This is in the US for adults age 18 to 59, male and female. Figure 4 shows a variation of men and women. The percentages of Finnish adults who indicated that they feel sexual desire at least a few times a week, right? Broken down by ages 18 to 19, all the way on up to 70 to 74. This is adults who indicated that if they could choose freely, they would like to have intercourse at least twice a week. So let's get into the disorders. Anal dyspareunia is pain occurring during anal intercourse. Perron's disease, condition in which calcium deposits in tough fibrous tissue develop in the corpora cavernosa within the penis. Priapism, or prolonged and painful erection occurring when blood is unable to drain from the penis. Physical causes of sexual function difficulties and dissatisfaction in men: diabetes, alcoholism, lumbar disc disease, multiple sclerosis, atherosclerosis, spinal cord injuries, prostate cancer treatment, smoking, bicycle-induced sexual difficulties, disease of the heart and the circulatory system. Physical causes of sexual function difficulties and dissatisfaction in women have to do with diabetes and heart disease, hormone deficiencies and neurological disorders, general poor health, extreme fatigue, drug use and alcoholism, spinal cord injuries, multiple sclerosis, dyspareunia, weak pubococceus, pelvic floor muscles surrounding the urethra and the vagina, endometriosis, ovarian, uterine tumors, and cysts. Psychological causes of sexual function difficulties and dissatisfaction. Immediate causes: fatigue and stress, inactive sexual behavior, sexual anxieties. Spectatoring, person becomes a spectator of her or his own sexual performance. Excessive need to please a partner. These are all pressures that are psychological. Conflict with self, internalized homophobia, self-hatred because of one's own homosexuality, and other relationship causes. The sexual function and enhancement, improving the quality of sexual relationship, developing self-awareness. What is good sex? We feel good about ourselves, our partners, our relationships, and our sexual behaviors. Discovering your conditions for good sex, doing homework exercises, mirror examination, body relaxation and exploration, masturbation. Develop your own erotic sexual voice, Kegel exercises, erotic aids or sex toys. Intensifying erotic pleasure, developing bridges to desire, sexual arousal, alternatives to intercourse. Focus on the task of daily living that you share. Expand your repertoire. Address issues with partner. Deal with unresolved personal issues. Do not become overly concerned with possible sexual problems. Embrace a deeper connection. The treating sexual function difficulties, Masters and Johnson's had a cognitive behavioral approach. The majority of sexual function problems are the result of sexual ignorance, faulty techniques, or relationship problems. Treated difficulties using a combination of cognitive and behavioral techniques. Treated couples rather than individual. The sensate focus on touch and the giving and receiving of pleasure. Table 2, strategies to cope with sexual difficulties. Take time, take note, and reflect. Changing circumstances to fit goals. The changing goals to fit circumstances. Living with a gap between goals and circumstances. So these are broken down into these 3 categories. Take time, take note, and reflect. The treating sexual function difficulties. So treating male function difficulties, erection difficulties, early ejaculation, the squeeze technique, where the penis is brought manually to a full erection, male orgasmic disorder, right? Treating female function difficulties. So the female orgasmic disorder or vaginismus is the scientific term for that. So common erection myths have to do with erection is something that is achieved. Another myth is men are sex machines, always ready, always hard. This is a myth. During a sexual encounter, you only get one shot at an erection. I blew it last time. I'll never get it up again. If I can have an erection, my partners can't be sexually satisfied. If I can't have an erection, then my partner will not be sexually satisfied. These are erection myths. Treating sexual function difficulties. So, how Kaplan viewed psychosexual therapy, modified Masters and Johnson's behavioral treatment program to include the psychosexual therapy, right? They use non-medical approaches, right? So they came up with the acronym PLISSIT, which stands for permission, the limited information, specific suggestions, and intensive model of therapy. Self-help and group therapy are also involved in the Kaplan psychosexual therapy. Women's most frequent activities to facilitate orgasm during sex. Positioned my body to get the stimulation I needed. Paid attention to my physical sensations. Tightened and released my pelvic muscles. Synchronized the rhythm of my movements to my partner's. Asked or encouraged my partner to do what I needed. Got myself in a sexy mood beforehand. Focused on my partner's pleasure. 65% thought how much I love their partner. 56% engaged in a fantasy of their own, right? These are all things that women did to increase the frequency to facilitate an orgasm. Treating sexual function difficulties. So the medical approaches have to do with lubricating gel or estrogen therapy, microsurgery to improve blood flow, Viagra, Cialis, or some folks use homeopathic products. So homeopathic is a science term for natural remedies, or homeopaths believe that the body can cure itself just through herbs or natural medicine, right? It's Eastern philosophy of medicine. We talk about gay, lesbian, and bisexual sex therapy, different issues than heterosexual. So homophobia, societal and internal may be an issue. Sex and HIV infection. This requires sex therapists to expand their understanding and treatment of sexual function problems. Wow. So this chapter, we learned about sexual function and dysfunction, right? Some of the things that we covered have to do with the sexual function and difficulties. We looked at several definitions. We looked at the different physical causes. We also looked at the psychology behind some of the sexual difficulties and dissatisfaction, sexual function enhancement, and last but not least, we looked at treatment. So again, this has been another opportunity for you to go back, look at your notes, reflect on what was covered in order to do well on that quiz or test or your written assignments that are in Canvas. This is Professor Alexander